Good morning, everybody. My dear students, semester 8 students. I'm here today to present to you a very important topic, which is a very common colonic disease. You can see this disease in the pictures uh, over there in the slide here. And I wish by the end of the presentation, you can come back to this slide and understand or try to understand what is going on. We will discuss every one of these photos later, and just remember that we are dealing with a colonic insult. So come back by the end and try to study what's going on. So the disease named Diverticulosis coli, and from the name we can show that this is a disease of form of diverticuli that arise from the colon. By definition, diverticulosis coli means a small intestinal pockets in the wall of the colon filled with a stagnant fecal matter of undigested food. So as you see in the attached picture here, you can see a part of the wall of the colon, and through these parts you find small pockets divertically. And these divertically is communicated with the lumen of the colon. So if we know that the colon contains some fecal matter, we can understand clearly that some point few centimeter of these fecal matter will pass to the divertically and stay inside. So it is a pocket coming from the wall of the colon and become filled with the stagnant fecal matter of undigested particles. The disease is one of the common diseases. However, male and female are affected equally. The incidence increases with age, and we find the disease more common in Western countries and is more common on the left side. If we studied why the disease is more common in the Western countries, it is said to be related to the use of a non-refined form of flour. So the food that's free of bran, free of cellulose, free of harsh matter that make the fecal content of the stool is harder, difficult to be evacuated, leads to a more kind of constipation, some sort of constipation, and this results in a stagnation of the fecal matter in the colon, and this stagnation will lead to increased interluminal pressure of the colon and stimulates diverticular formation. So this is why we consider the disease as the disease of the Western community, while those belongs to developing country are usually using food that contain a lot of greens, a lot of cellulose, a lot of bran. So these facilitate the evacuation of the colon, and we find the incidence of diverticulosis coli less in less developed countries. If we understand this slide clearly, if you know what's written here by heart and your mind going through the process to understand what's behind the story, it will be quite easy for you to um, consider everything coming next at an easy point. The pathology of the disease means that these diverticuli, these pockets, is actually a mucosa, is only a mucosa, is not the whole wall of the colon that extend to form a pocket. No, is only a part of the mucosa that extend to the outside to make what's called a false diverticulum. We call it false because it is not formed of the three layers of the wall of the colon, it's only formed of mucosa. So as I told you, the pressure, the interluminal pressure inside the colon, whatever the cause, caused by spasm, caused by constipation, by hard fecal matter, whatever the cause, this pressure push the part of the wall, part of the mucosa to the outside. And it usually comes at the point of weakness, which is usually near the penetration of the arteries to the musculoskeletal layer of the colon. So the wall of the colon has a musculoskeletal layer, and through this layer, arteries or blood supply go through the musculoskeletal layer to supply the mucosa. And this point of entry is usually a point of weakness. If there is a high pressure inside the colon, it pushes the mucosa to make a diverticulum, usually at this weak point. As I mentioned before in the definition, this diverticulum contains stagnant fecal matter, and the stagnant fecal matter is full of food particle remnants of the food particle plus a lot of microorganisms, so it easily leads to infection of the wall, not only the wall, not only the mucosal wall, but also the surrounding. And when infection extends to the surrounding, we call it diverticulitis. If the inflammation extends, a localized abscess can form, and abscess will collect in the area where the diverticuli leads to peridiverticulitis. If the peritoneum, the omentum, was able to localize the infection, abscess will be formed. But if the localization was deficient, the end result will be peritonitis. Whether abscess or peritonitis happen, the inflammation is extending, and once pus is formed, the pus will always search for a way to get to outside. So this continuous search of the formed pus to go to the outside will stimulate the diverticular inflammation to form a fistula. So to be connected with structure that have an access to the outside. So it can be connected to the urinary bladder, and in this case, the connection between the colon and the urinary bladder will result in a colovesical fistula. It can be connected to the vagina, and the resultant will be a colovaginal fistula. It can be connected to the skin, to the outside, and open on the skin, and make what's called a colocutaneous fistula, which is far less common than the other two kinds, far less common than the colovesical and colovaginal. So the continuous search of the pus forming to find a way to the outside will lead to formation of a fistula, just to as a trial, as a human body trial, to get this pus to the outside. It's not all that's happening in every case, but sometimes the case stops on the level of the peridiverticulitis or a small abscess formation, but recurrent attacks of this disease will result in narrowing of the wall of the colon, and sometimes colonic obstruction can happen. So if we went through the causes, what makes this happen? As I gave you an idea before, a low fiber diet, a diet free of fiber that makes the stool harder, and once the stool is harder, the intracolonic pressure is higher, and the stagnation of the stool is longer, and this will lead to formation of more diverticulum. Aging is another point. So the older age group are more commonly toward constipation, and constipation will lead to the same increased intraluminal pressure and diverticulum formation. People with colonic motility disorder, those who evacuate infrequently, those who have non-rhythmic colonic motility, will lead to stagnation of the stool inside and increase the formation of diverticulum. People using steroid or non-steroidal anti-inflammatory drugs, which has an ulcerogenic effect, it weakens the wall by its nature, so it can affect the wall of the colon and lead to the disease as well. If we went through the clinical presentation, the patient usually presents to us by pain, fever, anorexia, nausea, and vomiting. It is a pain plus criteria of inflammation. Pain plus fever, anorexia, nausea, and vomiting. The pain is usually on the left iliac fossa, to the extent that sometimes it simulates the pain of acute appendicitis. But Since the acute appendicitis is the right-sided abdominal structure, is the right iliac abdominal structure, this pain, the pain of diverticulitis, comes on the left side. So a lot of people say to be it is a left-sided appendicitis. It simulates the pain of the appendix, but comes only on the left side, or in most instances on the left side. The pain can mimic that of peptic ulcer, that of cholecystitis, that of pancreatitis, because all these people have an inflamed intra-abdominal organ, so all of them will present by pain and abdominal cramps, constipation, alternation of the bowel habits, fever, anorexia, fatigue, vomiting. So it can simulate, it can mimic other intra-abdominal inflammation. But constipation is a landmark here because it is a cause and a consequences as well. And this patient is liable for complication. I mean, as I mentioned before, he can come with manifestation of intra-abdominal abscess formation, manifestation of peritonitis, manifestation of colonic obstruction, manifestation of fistula formation if it is open on the renal bladder. So the patient will come to you speaking that he bring a fecal matter with the urine. If it open in the vagina, the patient will come to you that she is discharging fecal matter from the vaginal orifice. So complication can present with the patient as well. If you are trying to investigate the patient, the first uh, point will be a laboratory investigation, and of course, blood picture will mean a lot. So blood picture will give us an idea about having a kind of inflammation, and the landmark of the disease of the inflammation almost always is leukocytosis. So as long as the disease has some kind of inflammation, the patient has leukocytosis. Sometimes we need to do a blood culture if we are thinking that the infection is severe and the patient is going to bacteremia or even septicemia. I mean, bacteria or bacterial toxin are present in the circulation. So a blood sample could be taken and a blood culture could be done to determine what kind of organism is involved in such a process. The plain X-ray of the abdomen, erect and supine, will be of value if we consider some kind of complication. If the diverticulosis leads to colonic obstruction or something like that, so in the erect film you will find an air fluid levels, while in the supine form you will notice this is a colonic obstruction. So the X-ray, the plain X-ray, will be of value if we are looking for complication of diverticulosis in the form of intestinal obstruction. But actually, the X-ray will be of value if we did what's called a barium enema. Maybe you know that barium enema means that you will inject a contrast material through the anus. So a catheter inserted through the anus, you inject a contrast material that's commonly used as a barium. The name barium is the material that appear white in the X-ray. Sometimes we use different substance, but yeah, barium is commonly used. And the photos around here appear to have a barium injected from the anus and creep up to delineate the colonic wall. And you will see in the delineation, just like in the photo on the left side, that the wall of the colon is not smooth, is not a straight line, but it is ups and downs, ups and downs, ups and downs. And these ups and downs simulate the saw. So the appearance is named as saw-toothed appearance of the colon, just like a saw. And you can understand that the downs is the divertically, an area heavily invested by divertically can result in a downs formation. This is to let you know that Barium enema is one of the very effective kind of investigation to delineate the pathology, to delineate the diverticulosis. It's also important to detect complication, especially fistula formation. So if I inject a contrast material, if I injected the barium through the anus, and I found it in the urinary bladder, by any means, that has no meaning that the colon is connected to the urinary bladder, which of course is not normally present. If I injected the barium from the anus and I found it in the vagina, so by all means, there is a fistula between the colon and vagina, which is usually a resultant of a disease that could be inflammatory, such as diverticulosis. Ultrasound and CT actually does not add much except if the disease proceeds to complication. And the most common complication of the disease is abscess formation. So if abscess is formed, the ultrasound and CT can help us a lot because it can determine the location exactly. Usually it comes on the left side, so left iliac or left lumbar region. But not only the place, the size of the abscess, and the size of the abscess is a very important point during treatment. You will see it in a few minutes later. And how far is it? How close it to other intestinal lumen, to other intestinal structure, to the major vessels, to the ureter behind, to the urinary bladder. So what's surrounding the abscess, and maybe if we can drain it by percutaneous technique through ultrasound and CD guidance. However, by far the most diagnostic tool for a diverticular disease is colonoscopy. So colonoscopy is the views you see here where the colon is introduced, where the colonoscope is introduced through the anus to the rectum to the sigmoid colon and can scan the whole colon down to the cecum. And when you go through colonoscopy, by colonoscopy inside the colon, you will see these nests, these small holes or diverticular, these small pockets coming from the wall of the colon to the outside, and maybe you see it contains few drops of fecal matter. Colonoscopy is a very diagnostic investigation to diagnose diverticular disease. What's really important that you cannot do colonoscopy in the acute episode. In the presence of inflammation, abscess formation, complication, you cannot do colonoscopy because the colon is usually densely inflamed and introducing a hard structure just like the colonoscope can lead to its injury. So colonoscopy is of value while the patient is quiescent, is not in the acute inflammation stage. You can diagnose everything by viewing these diverticuli coming out from the colon. So if we thought about treatment, we can think about some different kind of cases. In the mild case, if the patient came to you with a pain on the left iliac fossa and he has been diagnosed by colonoscopy before that he has a diverticular disease, so fluid diet and antibiotic for few days until you get sure that the inflammation subsides, and then the patient returns to a semi-solid diet, and finally if a solid diet will be of major help. But if the case is severe, if the patient has a severe abdominal pain, fever, and abdominal tenderness, it is wise to send the patient to the hospital. And in the hospital, he or she should be kept on NPO, nothing per mouth. And nothing per mouth will give time to give a rest to this inflamed colon and to make the fecal content of the colon is more fluidy rather than solid and subsequently decrease the intraluminal pressure in the colon. The patient should receive an intravenous fluid and antibiotics and pain control And as I told you before, it is wise not to use non-steroidal anti-inflammatory drug because it's ulcerogenic. So we use a pain control is not belonging to non-steroidal anti-inflammatory drug. If the patient went to complication and an abscess is formed, we should determine the feature of this abscess, as I told you before, using ultrasound and maybe CT scan of that too. Any abscess smaller than 5 centimeters, it is wise to be drained percutaneously. So a needle under ultrasound or CT guidance is introduced to the center, to the abscess cavity, and left in place and leave in place a catheter, and the catheter is connected to a collecting bag outside, and it's left in place to collect this pus formed over a few days until subsequently we do another ultrasound, another CT to get confirmed that the abscess cavity is completely drained. So if the abscess cavity is less than 5 centimeters, we can drain it percutaneously using ultrasound or CT guidance. If the abscess cavity is more than 5 centimeters, or if any other major complication that happen, and I mean by major complication, fistula, intestinal obstruction. If these major complications happen, large abscess, fistula, intestinal obstruction, the surgical treatment is the only option. Actually, for any of the other cases, cases of mild disease, cases of severe disease, cases forming an abscess smaller than 5 centimeters and dealt with by percutaneous drainage, all of these cases, we should think about performing surgical intervention while the patient in a quiescent stage, while everything went back to normal. When everything went back to normal, we should think about surgical management of diverticular disease. That's to say that surgical treatment of diverticular disease is indicated for every patient after uh, going back to the usual, to the baseline condition, or if the patient has some kind of complication that cannot be resolved conservatively. So the list indicated in front of you define which patient is going for the surgical treatment, which patient will be sent to the OR, either patient of perforation, either patient of peritonitis, abscess more than 5 centimeters, fistula formation with the neighboring structure, recurrent attack of diverticulosis, patient of intestinal obstruction, patient of failed medical therapy, immune-compromised patient, and extreme of age patient. So a long list of patients, those should be prepared for surgical intervention. Sometimes the situation doesn't allow us for clear preparation. So we go to the OR on emergency conditions, just like the patient of intestinal obstruction, just like the patient of peritonitis. So those patients are treated surgically, but on an emergency situation in a non-elective condition. But the patient with recurrent attack can be prepared for surgical intervention and go while the basic condition is normal. Here we have to talk about colonic surgery in general and specifically toward diverticular disease. If you are going to resect a part of the colon here to get this part out, to surgically manipulate the colon, this could be done on a one-stage surgery, on a on a one-stage surgery, on a two-stage surgery, and even on a three-stage surgery. Now I'm here to let you know about another diverticle, which is completely different from the one I was talking to you about. I will tell you about another kind of a diverticular disease that's called Meckel's diverticulum. As you can see from the picture here, the Meckel's diverticulum is a disease belongs to the small intestine. You can see the cecum ascending, transverse, and he's a part of the descending colon. But the Meckel diverticulum is not a disease of the large intestine. It is a disease of small intestine. And by Meckel's diverticulum, we mean persistence of the proximal part of a structure called vitellointestinal duct. Maybe you remember this structure. You can see the structure here in the next photos, that there is congenitally a tract that connects the small intestine to the region of the umbilicus, which is called the vitellointestinal duct. This tract is usually get obliterated, get atrophied, and disappear by the time by the time of intrafetal growth, and usually disappeared completely. Persistence of the proximal part, and by the proximal part I mean the part toward the small intestine. Persistence of the part that's coming from the small intestine leaves a diverticulum which is called a Meckel's diverticulum. In the next picture here, you can see the whole complication that can come from vitellointestinal duct. The upward one here is classic Meckel diverticulum. The proximal part is left. But the one here is the persistence of the proximal part while there is an obliterated tract toward the umbilicus. There is here a band between the small intestine and the umbilicus. There is here a fistula or a tract, a complete tract, completely persistent vitellointestinal duct between the small intestine and the umbilicus, and you can imagine if the tract persistent completely, the umbilicus will discharge some kind of fecal matter, something like that. Here there is a persistence of a part in the middle, so a cyst is formed in a tract connecting the small intestine and the umbilicus. And here is the persistence of the distal part, where the part at the umbilicus is not obliterated, while the remaining part of the tract is obliterated. So by Meckel's, we mean a diverticulum that comes from the small intestine, and it is a result of persistence of the proximal part of the vitellointestinal tract. Actually, it is the most common congenital anomaly of the small intestine. It is the most common anomaly of the small intestine that you can see. And what is letting me to speak about Meckel's diverticulum now is to let you know that Meckel's is a true diverticulum. It is not a false diverticulum, just like Diverticulosis coli. Diverticulosis coli is a false diverticulum because it is formed only of mucosa, while Meckel's diverticulum is formed of complete small intestinal wall. The three layer of the intestine is represented there. The Meckel's diverticulum has a famous statement because it's called the disease of two. And we call it a disease of two because it is present in 2% of the people. It presents in males more than female, 2 to 1. It's usually 2 inches long. It is located 2 feet from the ileocecal valve. It usually contains 2 kinds of ectopic epithelium. And 2% of the people having Meckel diverticulum will experience some kind of complication. So it is a disease of 2. It appears in 2% of the people, 2 times male, 2 females. 2 to 1, I mean, 2 males, 1 females. 2 inches long, 2 feet from the ileocecal valve, 2 ectopic epithelium, gastric and pancreatic, and 2% complication of these cases. The clinical presentation of a Meckel diverticulum is very resembling to diverticulitis. And when I'm telling you that diverticulitis is resembling pancreatitis but on the left side, so Meckel diverticulum is resembling appendicitis as well, and it usually comes in the middle of the abdomen or on the right side. But by far the most common uh, presentation of Meckel's diverticulum is being symptomless and accidentally discovered while doing any kind of surgical intervention. Doing appendectomy, doing cholecystectomy, doing whatsoever, you will find a lot of patients, 2% I mean, of patients with a Meckel's diverticulum that never produced any kind of symptoms. But once it is symptomatized, usually it presents like acute appendicitis or acute diverticulitis. I told you that there is some kind of ectopic epithelium inside, and sometimes it is a gastric epithelium, and the gastric epithelium can bleed. So bleeding can be the symptomatic factor of diverticular disease. It is a bleeding from the small intestine, so it presents like a melena. So bleeding could be one of the presentations. As I told you, it could be connected with the umbilicus, just like a band in between. So any band between the small intestine and the fixed structure, just like the umbilicus, can lead to intestinal obstruction because of this fixation of a lobe of the intestine to a point, just like the umbilicus. Chronic abdominal pain is usually a common finding, and it's not easy to define this pain as being related to Meckel's diverticulum until you explore the abdomen and discover the presence of a Meckel. If the Meckel discovered accidentally, just leave it in peace, but landmark the patient that he has a disease called the Meckel's diverticulum, and it can lead to some kind of complication. The patient has to know that he may be symptomatic later on. If the patient is symptomatizing, resection of the Meckel diverticulum is usually the correct treatment. I hope this was very effective to you. This one of the nice picture that I took in UK. I wish you got some kind of experience over there. And I also wish that my presentation was fruitful to all of you. Thank you so much.